Right, good afternoon everyone. Very exciting time for you to be starting your training here at the conference. I hope it's going to be I know it's going to be a life-changing experience for you. The conferences, as Alice was saying, they're intense and very, very exciting, and I love this journalist training program. I think it's a fabulous way to get people like yourselves really well briefed in a whole area of knowledge, and to be motivated to really, in country, bring a lot of attention to these areas that we're so passionate about. I'm going to be speaking about asthma today. I'd be interested, who has already maybe got interested in asthma or written something about asthma before, out of you? Just showing with your hands.
Well, I've presented shows on asthma a number of times, as to getting into the causes, as to why it happens, what are the kinds of signs and symptoms that one should be on a lookout for, and how to manage the disease. So
so you've done quite a lot.
So I have done shows on that, television shows on that.
Okay, great. I've never been on television.
Here's an opportunity. I see a match made in heaven right here.
Has anybody else written or been on television?
Yeah, I have not a whole lot, but the city I come from, it's a coastal city and it's very polluted. And we are seeing increasing incidences of asthma and allergic asthma to the extent that it's debilitating people. And they are coming up with new drugs and drugs that people are on constantly, but not responding very well. They're trying to formulate drugs which will do better for Karachi in particular. So it's problematic, and so I've written about it.
Written about that as well. I think, as Alice was pointing out, asthma doesn't kill a lot of people, and this is part of our challenge with asthma, is that sometimes governments and donors only concentrate on diseases that kill, because that's what everybody's worried about. They're worried about dying from things. Yet, as you say, asthma is debilitating. It stops people from working, looking after their families. So it really affects their quality of life. And not being able to breathe is that's fundamental, and a very, very scary thing if any of you have asthma yourselves or family members who have it. So we believe that we should not only be working in diseases that kill most of the people who have it. We believe that quality of life and countries' economies need to be taken into consideration. People's ability to have active, healthy lives. Right. Okay, so now I'm going to be challenging you a bit this afternoon. I'm going to be talking a lot about access to medicines. And this is partly because the project of the Asthma Drug Facility at the Union, which is something we started in 2005, I'll come over to this a little bit more, is based on the challenge for asthma of access to medicines. And I think it's very important to spend a lot of time with you on this access to medicines focus, because often people do not realise how much of a challenge this is for countries, and in particular low-income and middle-income countries that are working in asthma. We in fact have seated with us Professor Asthma El-Soni, who's one of the past presidents of the Union and who works in various areas of lung health, but does work on asthma and has been working on approaches to asthma. So Asthma El-Soni sitting at the back there would be a wonderful person to interview at some stage if you would like to speak to somebody who's been running activities in country, working closely with us at the Union. Okay, I have two presentations. One is from the pharmacist coordinator of the Asthma Drug Facility at the Union. His name is Christophe Perrin, and he is at the World Health Organization today, but we work together very closely on the Asthma Drug Facility, and he has prepared some slides for us to talk this afternoon about the pharmaceutical market and all of the things that we need to take into account for the realities in countries about asthma medicines. And the second presentation that I'll make during this session is a look at the asthma drug facility from 2005 to 2014, because unfortunately the union has had to decide to close the operations of the asthma drug facility due to financial constraints. But this presentation will allow us to look at all of the work and the objectives that we hope to continue forward for the asthma drug facility. Now, I'm going to try and keep this free of jargon, or at least I shall transfer the jargon to you so that you are able to become familiar with this when you're speaking with people and reading articles and writing things. But please do interrupt me if there's something that's not clear or that I haven't explained. So, as you will imagine, medicines represent a lot of money. There are a lot of people working in medicines who are there to make money, keep companies going. They're not all like us at the union who are public health, passionate about public health and health outcomes for equity in health. So it's a big market, and it's important for us to understand what we're working in, what countries are working in. So in 2011, $956 billion worth of pharmaceutical market. This is big money. People make decisions based on a lot of money. When countries are supposed to be also taking into account health guidelines when they make decisions about what they buy, you can start to understand what governments and ministers of health are also being influenced by. Now, there's also a very big difference between the countries and the world. Sub-Saharan Africa accounts for less than 0.5% of this amount of activity in the pharmaceutical market. So a lot of activity is in the high-income countries. A lot of medicines are generated there, all the research and development money there. And the countries that benefit the least from this and that struggle probably the most with the access to medicine are the low-income settings. And up to 90% of people in these poorer or low-income countries have to buy the medicines themselves. Out of pocket means they are purchasing medicines with their own money, no reimbursement, and often very little guidance as to which medicines they should buy. And a lot of research has been done to see what people spend on medicine, what they would have bought with their money if they didn't have to spend it on medicine. It's often something that is taken instead of, they buy food, and then the second thing that they would have to spend on is medicines. So it can be a huge component of the small amount of money that they earn for their families. And then we have a market that used to be, before 1990s, it used to be that most of the medicines were produced in high-income settings, and they were then sold to or purchased for low-income settings. Then less than, let me see, there would be a little light there. Yeah, so less than 5% of medicines were generic medicines. Are people clear with the term of generic medicines? Generics. The terms we use are innovator products or reference products and generic products. So the innovator product, that is one that a company has developed and produced themselves. And then generics are when it comes off patent and other companies are allowed to make that and sell it themselves. So those are generics. And generics should have a lot of good press because they can be made to exactly the same quality standards as innovative products. So as long as there is a good quality assurance system in place, your generics are as good as having the innovative products. the market today is very different. There are a lot of companies in low-income settings, middle-income settings, that are now producing medicines, and some of those are going in the other direction. They're coming back to high-income countries now. So as you can see, we've now got more than 50% of worldwide prescriptions are generics, so a big change there, and huge differences in the amounts of generics and the direction of the flow of these medicines. Now, unfortunately, in many countries, and a lot of them low-income countries, the regulatory authorities have not come up to the standard that they should be in order to deal with this change in the markets. So in many of the countries, the regulatory authorities are not strong enough, and sometimes it's because they don't have enough money, funding from the government to do so. They don't have enough human resources to do so. So there are problems with regulatory authorities in countries. It's quite a transitional process in many countries to get good regulation for medicines. So this means that a number of countries are importing medicines or purchasing locally produced medicines without necessarily having good quality assurance systems in place and good regulation. So we do find that there are a lot of poor quality medicines circulating. So this quote is quite scary. According to WHO, it is estimated that up to 25% of the medicines consumed in poor countries are counterfeit, so they're copies, they're fakes, they're not real, or they're substandard. That means they're aiming to be a quality medicine, but for some reason they don't meet the standards. And in some of the studies, it's been up to 44% of medicines have been counterfeit or substandard, very high. Now, the next few slides are a few more examples about these the ways in which medicines can be poor quality. The WHO list that you see here, it's something very important for you to be aware of. It's called the pre-qualification list, and this is where the World Health Organization takes some of the very key medicines for tuberculosis, HIV, malaria, and does what they call pre-qualify. So they call for expressions of interest, they look at the quality of medicines, and then they publish medicines that are produced at particular manufacturing sites, and that's public information that all countries can look at. Therefore, you know that you're buying quality products. So that's an excellent scheme at the World Health Organization. It takes a lot of money, so they don't do it for all of the essential medicines on the World Health Organization essential medicines list, only for some of the key ones, for example, TB, HIV, malaria, and some reproductive health and avian flu medicines. Now, you'll notice that I didn't mention asthma, so that's going to be one of the things we come back to when I talk about the asthma reality. Now, for these other medicines that are on WHO's essential medicine list, that's perhaps another thing to clarify. Has anybody looked at the essential medicines list of the World Health Organization? Are you familiar with that document? Yeah, it's essentially the list that is the WHO's recommended medicines, the basic recommended medicines that countries should refer to when they want to develop their own national essential medicines list. And it is the basic medicines that each country should have available for their populations. There are some differences, obviously, if a country doesn't have one particular disease, the burden of disease is not high, maybe they do not have that on their essential medicines list, but that's the reference document that countries should turn to for their own medicines. But there is no international mechanism guaranteeing the quality of the the quality of these products and manufacture. So countries are still left to their own devices to find out where they should procure things. Now, HIV/AIDS, these are just a few examples. The next 4 to 5 slides, Christoph has prepared some of the examples of what can go wrong with purchasing pharmaceutical products. These were some falsified HIV drugs. This was found in Kenya. So that if you'll be getting a copy of these slides, so we've placed the documentation to the left, so you can follow up with those if you would like to. But these are all documented cases of poor quality medicines. Then in chronic diseases, there was 120 deaths from a contaminated drug that was used for heart disease. So it can be really very, very serious, these problems. This was something used in a hospital as well. This was not something bought on a market or from a stall. This was a product that got to be used in a hospital. Lots of problems with antibiotics, and of course antibiotic resistance is growing phenomenally because of the misuse of antibiotics, and it's a very, very serious problem that affects all countries in the world, with counterfeit and substandard medicines, this is increasing this problem. Intravenous fluids. Now, there's a lot of problems with these, with contamination, with fluids not being kept at the right temperatures, so people are actually poisoned by fluids that can be given to them in health centres. There you can see the dirt and grime that's circulating in something that's about to be put in somebody's body in a hospital or health centre. Here's some results from the field of malaria. Anti-malarial drugs. For example, in Ethiopia, 41% of the products they looked at weren't even registered in the country. So there's a regulatory problem there. They're on the market somehow, but they haven't come through the authorities. Nigeria, the possibility of being treated with an anti-malarial that complied with quality standards was less than the possibility of receiving substandard medicine. So they were getting a lot of substandard products. 60% chance in Ghana and Cameroon of getting good quality medicine. So it sounds like a bit of a lottery if you're a patient with the medicines, which is a terrible, terrible reality. So I won't go through all of these. I'll leave those for you if you want to look at a summary of the things that can go wrong with medicines. So whose responsibility is it to be looking at medicines? Now, I've mentioned the national authorities, so this is when it's referred to as the NRA here, those are the regulatory authorities. And around there you see some things: resources, political commitment, political will, interests and lobby groups, things that influence the market in countries, influence what's going on. And that's right through to corruption that we're having to deal with there. And here we have a quote explaining the fact that a lot of these regulatory authorities have a lot of constraints, chronic shortages of human resources, trained human resources, technical resources to do their work, finances to do their work. Sometimes it's not a country's in inverted commas fault. It's that they just don't have the access to the resources to do the work as they would want. And this is a study from the WHO that looks at the quality of the national regulatory authorities and their ability to look at the quality of medicines. So as you can see, quite a lot of those are the 39% had limited ability to look at quality of medicines. This is the comparison between a country like Denmark. You can see their yearly resources spent on looking at quality of medicines. 31 million for a population that's 5.5 million. Sub-Saharan Africa, in theory, 0.64 million, in practice, 0.12 of a million, 3 staff to work on it, and for a population the same size. So there's a big discrepancy, and this is a neglected area of healthcare. People are not giving enough attention to the issue of medicines. So what else influences the medicine purchasing process? You've also got the agencies that actually procure the medicines. All sorts of interests can come in there. Then you've got international organisations that purchase the countries with their own interests, their own ways of doing things often, which really complicates things. And I'll show you a fabulous diagram about Burundi and the number of organisations involved in healthcare there. And then, of course, not to forget other people who can confuse the issue out here. Donors giving money and wanting perhaps to purchase in particular from particular manufacturers. So a whole lot of things that can affect what the patient actually gets. This is a very good, this is the ideal situation for how medicine supply should work. There should be harmonisation between donors and countries and discussion and alignment of policy and purchasing, but unfortunately this remains an ideal scenario, and that it looks like something that describes a genome or DNA or a complicated NASA computer. It's actually the procurement systems for pharmaceutical products in Burundi from 2007. And along here, you've got the sources of financing mechanisms, WHO, UNICEF, MSF, all these different ones. Great giving money, but very, very complex. So how do you keep track of medicines that are being purchased in all these ways? And sometimes international mechanisms can influence and override national decision-making mechanisms, which is not a good scenario at all. So in conclusion from this presentation here about the market and what's going on out there, what influences access to medicines, we've seen, particularly since 1990, a phenomenon of globalisation in medicines. There's a lot of outsourcing of various parts of the process, subcontracting. The supply chain is now very, very complex, and every time you get something, a different person or a different process in the supply chain, the possibility of quality problems increases. A lot of standards to follow. There's WHO standards, obviously, which we believe to be the standards that everybody should be referring to. But then there are also other regional standards, and a lot to consider there. Countries often have difficulty applying different standards, working out what they should be using as well. And then this, for me, the third point here about quality control and quality assurance is a very, very important concept. And I've noticed that this is something that a lot of people misunderstand. They mix quality control with quality assurance. Quality assurance is the whole system. The quality assurance system is something that needs to take place in a country in order to follow every single part in the chain of actions that starts from when you decide which medicines you should purchase for a country, right through to writing the product specifications for the advertisement for manufacturers to respond to, who looks at the products and assesses the quality, how the tendering process goes for prices, right through to when that medicine gets to see the patient. So it's the whole system, quality assurance, and there are risks of poor quality at every single part in that chain. Quality control is when you go in and you check, you take a sample and you just check the quality of something. that is one small step, very important step, but it's only one part in the chain. People tend to think we've got quality control being done on the products when they arrive, before they go on the boat, before they go on the plane. We've got quality control organised. There's an international agency that looks at the products and tests samples. That's not enough. If you wrote the product specifications for a product incorrectly, if you don't have a good system for assessing manufacturers' dossiers about products, if you don't have a system for going back to manufacturers and checking their production sites on a regular basis, if you don't have terms of reference for the type of people who should be looking at the manufacturing sites, then you've got quality issues and your quality assurance system is not sufficient. So I think if you can really remember that quality issues can appear right through the chain, and the patient is completely vulnerable when they go to the hospital or they go to the market to buy something, and they are in a very vulnerable position if all of these things have not been attended to. Right. Now the last bullet point, we've got a lot of people talking about the price of medicines, which is good. We want to get the prices of medicines down, but a lot of international actors and people who mean well but haven't informed themselves sufficiently try to get prices down. They try to negotiate prices down for perhaps particular projects that they're supporting, and they compromise on quality. They're so focused on getting the price down that they compromise on the quality. So this is something that we at the union are very focused on. Yes, we get the prices down, but we have to keep countries and ourselves looking at the quality as well. It's not something you can sacrifice. Okay. Now at the end of that presentation, a whole lot of references. Christoph has put that in if you want to go back and refer to something for your documents, your releases or anything. Now, how are we going for time? That's good. Would that be a good place to just ask for some feedback, some questions, or maybe some examples from your countries if you've seen some problems with quality of medicines or any qualifications you'd like about those?
Yes. I wanted to say I'm a little surprised you did not mention an innovation in Ghana called M-Pedigree. And in case you haven't heard of it, maybe I could explain it to you.
Mm-hmm. Yep, sure.
But have you heard of it or have you not heard of it?
Could you say the name again? I couldn't hear.
M-Pedigree.
M, yeah.
As in mobile pedigree.
Oh, I see. M as, okay, right. I haven't heard about it, and possibly others haven't as well. So do explain.
Yes. So what it is, it was actually an innovation which followed on one which came up in Kenya. In Kenya, we do a lot of mobile money transfers. System called M-Pesa. Money, Pesa is Kiswahili for money, M for mobile. And this was in reaction to the fact that we have extensive extended family system. We're always sending each other money, lending each other money. So this Ghanaian came up with something which I think is ultimately even more significant. I've never been to Ghana, but I know how it works. If you go to buy medicine in Ghana, there's usually the serial number on the back of the drug. Mm-hmm. Yeah, you send a text message with that to a centralized database, and you get an immediate response as to whether that medicine is approved or not, as to whether that medicine is counterfeit. Mm-hmm. If it's counterfeit, it shows immediately. Mm-hmm. And this is for the very reasons you listed, that most poor people end up buying their own medicines, and they have no idea what they're buying. Someone told them, well, just go and get this. And it has actually substantially reduced the use of counterfeit drugs in Ghana. Kenya is hoping to copy it. In fact, as we're Just speaking, I did a quick check on Wikipedia just to see if it's there. And it is mentioned, if any would like to Google it. It's M pedigree, PEDIGRRE, yes.
Yeah.
So I think that's a major innovation which may go a long way towards helping, because the problem, as you say, whether due to corruption, incompetence, or just ignorance, many poor people, the people who can least afford it, end up buying medicines which don't cure them.
Or are going to make things worse.
Yes.
It is unfortunate that it has to be the patient who has a mobile phone, who checks with the medicines. I think it's a great innovation, and I would very much like to read more about it. I hope that we can also improve the quality of the regulatory processes in countries, so that we eliminate a lot of this, a lot of the problems, so that more of the drugs are good quality and known good quality already. But yeah, that's very interesting.
I wanted to ask about generics, because
Yes,
I'm from Russia, and generics are very popular in my country, especially from India.
Yes.
All generics comes from India, and but as I heard from doctors, generics are not good. You said that I mean in Russia, I don't know, maybe somewhere they are good quality, but serious doctors, they don't recommend generics. And I mean, when you are talking to them like a journalist, and what would you recommend? What is the real treatment of this or that disease? And but when patients go to doctors, they give them this prescribe these generics. So what do they? What is your attitude to generics? Is this like a normal situation with these kind of treatment, or it's a lot of fake things that are considered to be generics all over the world?
Right. Well, generics that have been through a quality assurance process are going to be of exactly the same quality as an innovator product. So a generic is not poor quality. It's not. However, a generic that has been through no quality assurance system, you don't know what's in it.
You never know whether it got through the system or not, because it is just prescribed and you go to the pharmacy store and buy it.
But if it is in the country, if it's gone through the system, if the quality of the regulatory authority is good, then that generic will be of equal quality to an innovator product.
Can I check somewhere?
I just want to make sure, because other people have questions, so try to limit to one question so we make everybody.
And the other thing to be aware of is that, and this has happened in a lot of countries, there's a lot of attempts by the big pharmaceutical industry to give generics bad press. So they say bad quality, don't use them. And the people who are influenced by that are often the specialist doctors. So the big pharmaceutical companies, the innovator companies, that often take people to dinner, give them free samples, give them, in some cases, huge financial incentives to be very loyal to the company, influence that whole decision-making process. So that's why we often find in some countries, that the specialist doctors will prescribe by the innovator name instead of using the basic generic name, which is already influencing the patient. So hopefully the pharmacist is going to think about the health system and the costs and is going to propose a generic to the patient. Because those generics that have got through the system that have been, they're of quality. And we'll see, I'll move on now actually, that's a good way to get into the asthma drug facility presentation. Get out of that one, end of slideshow. because we have used generic medicines. There we go. Good. From India, from Bangladesh, and they've gone through the quality assurance system. So that's for us, and according to the WHO standards and norms, those are equal quality. This is very interesting. I see some heads nodding when we talk about the bad press that generics have been given, and you need to think about the influences that are in that. There's a lot of money. Remember that billions of dollars in the pharmaceutical industry. There's a big incentive for the big pharma to make people say you take Serotype for asthma as opposed to you take beclomethasone or salbutamol, basic names of the molecules. So, yeah, you've got to perhaps
actually, like what Ma'am was actually talking about, the generic drug. Like, India as a volume, the third largest manufacturer in the world for the generic drugs, and for the when talk about the price, the 10th largest. Now, when we are talking about the generic drug versus the the quality drugs and when the patent drugs, it's not like that. If suppose all the journalists are actually writing about the generic drugs, there are possibility that we may take 5 to 10 years to communicate this thing that generic drug is as quality wise is as good as the patented drug. The problem is actually related to the patient and the doctors. Like in our country, doctor is equal to God. Whatever doctor is saying, you never go and cross check why he is actually giving you those medicines, why he is actually asking for the diagnostics, why they are talking about the test. Now the problem with the doctors are for the last 10 to 20 or 30 decades in India, doctors are always saying take some good medicines and take patented drugs, take quality medicines, and until unless the package of the drug is not that much attractive and good, now the patient is not willing to get it. When you're talking about the out-of-pocket expenditure, okay, every year 2% of the common above poverty line people are going below poverty line due to the treatment. But it's related to the doctors, it's related to the industrialists who are the manufacturers who are actually giving lot of money. It's not only about the good gift, it's all about the every year they are more than 30 to 40% of their income is only for the doctors to visit them in the abroad for the different so-called of medical tourism and for the medical teaching.
Medical tourism. There's a good topic. There's a good piece of jargon.
Yeah. So they are.
Do you have a question for her? Or
Just wanted to ask because you're talking about the quality drug. Now when we are saying that that the faith of the common poor patient is not on the generic drug, then how the people will actually use it?
Yeah. So this does lead in very well to the asthma drug facility because it will help you understand why such mechanisms are necessary right now in order to solve some of these problems about people thinking that you can only buy the very expensive innovator products. And this is part of why those 235 million people that have asthma around the world, why they don't access, the majority of those do not access medicines, because you have a situation in countries where only the very expensive branded medicines are available, so only the elite in the country can afford to buy it. So all these people going without medicines for their asthma because of this situation that the pharmaceutical industry is influencing enormously. Right, so let's get on with asthma drug facility. So this is a project that we started at the Union in 2005. Essentially, a lot of international actors have been talking about all these, many professors, many esteemed people have been saying one of the reasons why we cannot treat asthma properly, manage it properly in countries is there's no access to medicines. We can't get the medicines. And the Union waited to see is somebody going to take the lead? Is WHO going to take the lead? Is maybe a big donor organisation going to take the lead and try and help solve this problem? No organisation stepped forward, so the union took it on as a project to see how can we work on this problem of access to medicines for asthma. So we created the Asthma Drug Facility, 2005. Have you heard of another drug facility, another mechanism in lung health before? Maybe not, depends how much you've looked at the
Global TDF?
Yeah. Global TB Drug Facility, the Stop TB Partnership created that to work on TB, access to TB medicines. And I might get you to do some brainstorming about the differences between TB and asthma in countries, because this will be an interesting thing for you to take away from this session. So we created the Asthma Drug Facility, and in 2 sound bites to provide affordable for the patient and affordable for the country, access to quality assured, there's that quality assurance concept again, essential asthma medicines. Now the essential asthma medicines are the ones that are on the WHO essential medicines list. They're not the fancy, high-tech, latest, brightly coloured, branded medicines necessarily. There are the essential asthma medicines that the World Health Organization says are good for the management of asthma, and they know them to be affordable and something that can feasibly be applied in low and middle income countries. Our second soundbite there, we promote a quality improvement package for the diagnosis, treatment and management of asthma. So the union didn't want to just create a mechanism that was going to basically sell drugs to countries. That's not what we wanted to do. We wanted to work with countries on improving the management of asthma, so the technical knowledge of the union could be developed by working with countries who were willing to take this on, and then to also do all of the quality assurance process for them, so that that's all done and paid for, so that the country knows they're getting quality medicines, and the whole procurement process is facilitated for them to help them get these medicines into countries. Because a lot of the countries simply are not procuring asthma medicines. It's okay in India and Pakistan, perhaps, where the generics are very easy to get hold of and affordable. A lot of other countries, simply no medicines for people with asthma. So that's what we set out to do in 2005. We set up a quality assurance mechanism based on WHO norms and standards. And as I said, the inhalers are not part of the pre-qualification process of WHO. So we worked out that we had to do that ourselves, which is quite it's a complex process and hard for countries to go through this process as well. So we tried to facilitate that. And another concept, I think, which is really important for you to understand if we're talking about access to medicines, here, this concept here, contracts are for qualified product site pairs. So this was a revelation to me when I was working, because I'm not a pharmacist. I learned all of this through the process. You don't just qualify a product from a manufacturer, because that product might be made in Mumbai, or it might be made in another part of the country, it might be in a different manufacturing site, and when the people have gone to check the quality of a particular site, you want to know that the product is going to come from that same manufacturing site that you looked at. And you want to know that it's going to be made with the same ingredients that they said they were going to be using. So it's not okay to qualify just a product. It has to be a product that is made at a particular site. So it's a complex process, and companies can get around what they should be doing if this process is not done properly by the quality assurance system of an organisation or country. So we tried to get lots of orders together so that we could keep the prices down. We did international tendering, got the prices right down, and we accompanied this by the union's technical guidance at the management of asthma, which is based on many years of work in the field with countries that have developed programs to look at asthma as part of a comprehensive approach to lung health improvement. I think the last sentence here is also key to understand our approach. Asthma patients often end up going to hospital. If they don't have medicines, they have asthma attacks and they end up in the hospital in a terrible state, families rushing them and not being able to breathe, no idea what's happening or what to do. Well, they know what's happening, but they don't know what to do. So often the patients, you can track what's going on in a health facility by seeing how many patients come into the emergency, how many are hospitalised because of their asthma. And if you can have a program like the union recommends, where you track the number of people who are admitted in emergency and hospitalised for their asthma, and you show over time when they are given proper asthma care, proper medicines, you can see a drop in the numbers. That I can guarantee. If they have proper care, educated about how to use their inhalers, there will be a radical drop in the number of people who end up in the hospital. So we need to be able to show this in order to get change and get governments buying medicines and supporting asthma activities in countries. So what did the Asthma Drug Facility manage to do over these 2005 to 2013? We ran three rounds of product and site qualification. We ran you have a qualification process, and then for the qualified products, you ask the companies to give their best price, and then you take those products with the best price. That's what we did. We did three of the qualification and 2 of the tenders. Unfortunately, the operations were closed just prior to doing the 3rd tender, so we don't know what the prices would have been for 2013-14. But we have managed to run this mechanism, and hopefully it can be a model for another agency to take on and for other NCDs to try and improve access to these medicines. We managed to work with a number of producers of generic medicines, and then also got which worked very well. They kept the prices and they even decreased the prices. And then we had an innovator company, GSK, that presented product dossiers, and we were very interested in this because it had obviously become a mechanism that even the innovator companies were interested in participating with. So we've seen some changes in countries since 2012. This is an important finding. The innovator companies, and this is in a number of the African countries, have now got tiered pricing so that their prices are still higher than what we were getting, but it was better than what it was before. So there's some kind of influence even in the innovator products. That may sound to you still not fair because there's tiers and prices, but it's actually quite a realistic trade mechanism, and as long as there's some lower prices, then that's good. Now this graph shows what we managed to achieve in 3 of the countries, or the countries themselves, Benin, El Salvador and Sudan, and it shows their prices. The light blue is the prices in 2009 when the countries were procuring those medicines as usual, and then in 2010 when they procured through the ADF in 2012. So you can calculate almost half, some of them are over half as much again that they managed to save. So those prices are in euros. a very big reduction, which means a lot for patients and health systems. And then, you know how I was talking about hospitalizations and emergency visits. We did some very, very basic calculations. We need a health economist to work with us on this, but just did some very basic calculations about how much does it cost for a patient to be hospitalized for their asthma. Okay, so these are in just looking at cost of hospitalizing a patient for 2 days, 4 times a year, which is quite a realistic thing for a person with asthma who has no medicines and no appropriate care from the health facilities. So that's, for example, in Bennett, you cost €269. How much would it cost to buy 1 year of medicines for them? €48. So you can work out how much health systems are actually they're paying by not looking after people with asthma. They're actually paying a whole lot more for the people in their populations who have asthma. Unfortunately, this type of study hasn't been done in enough low-income countries for governments and ministers of finance to wake up and see why they should be looking at asthma and trying to get people looked after with medicines and care. This is a wonderful cartoonist, a guy from Pakistan who did some cartoons for us. So this is we said we would like to show how asthma is dealt with if you don't give people the basic medicines they need and they end up in the hospital. So we said it's like throwing money out the window. So here's a person who shouldn't be in hospital, shouldn't need shouldn't need nurses looking after him, a bed. It's like throwing money out of the window if you're not looking after their asthma. And obviously not just money. You've got a patient who's suffering, a family who's suffering. It's unnecessary. I won't go into all of the details about the projects that we've done. You can read this and maybe look to some of the countries and see if there's countries you're particularly interested in, and we can put you in contact with people. Out of interest, I'll draw your attention to this line here. We had some countries that wanted to purchase medicines because they had money from the Global Fund to fight AIDS, TB and malaria, and within that there used to be the possibility to purchase asthma medicines because it was looking at practical approach to lung health, which is another strategy, name of the strategy. But that included your patient who comes to the health facility with a cough or breathing difficulties. They might have TB, they might have asthma, they might have pneumonia, but they're a patient who's got difficulty breathing, and the health centre needs to know what to do for them regardless of what they have. So the Global Fund did allow that, and some countries were going to be purchasing medicines through that because they couldn't get governmental resources in any other way. Unfortunately, the conditions changed and the Global Fund no longer allowed that, so that they cancelled their attention. That's just to give you an idea how fragile asthma is in countries. You've got your health programs, healthcare workers, often TB people who are concerned about asthma, who are trying to do something for asthma because there is no other structure for looking after asthma in the country. I won't go into the new types of clients. Now this is the section of the presentation where I draw your attention to a movement which you hopefully can be aware of for the better attention to non-communicable diseases, NCDs. So the UN in 2011, this is a very important meeting that happened, it was called a high-level meeting, and it was the first time really when governments from around the world came together to acknowledge the huge problem of NCDs, by no means only in high-income countries, but acknowledging the huge burden that middle and low-income countries are now starting to have with non-communicable diseases. So the ADF has been involved in a lot of this submissions for these documents and contributed to getting asthma and chronic respiratory disease into those discussion documents. So we're coming at the problem hopefully from high level as well. These are some more references that might be useful for your reading about asthma. Publication, I won't go into that in detail either, that's there for you to read, but it's about the prices and the affordability of medicines in 52 countries. So there's a lot of graphs and results on prices and affordability for people in low-income countries there. This is just an example of the type of work that we did. On this axis, the days of work that a person in the country, the lowest skilled, a non-skilled government worker, lowest paid non-skilled government worker, the number of days that they would have to work in order to purchase one of these inhalers. So you can see there's a lot of people are having to work a huge amount of days just to buy an inhaler. So they're essentially not going to be able to buy them. They're not affordable. Also talking about the sort of the global policy and advocacy that needs to be part of the equation for improving access to medicines. There's a global asthma network, and I'd like to draw your attention here to a presentation or plenary by Professor Ines Asher. She'll be doing her plenary on the 2nd of November, talking about global asthma network. That'll be a very good place for you to hear more about global asthma. Let me just think. Now, I'm going to spend a little bit of time here. Let's just ask you a few questions now. And this is going to depend on whether you know TB programs and in your countries perhaps, but what do you think are some of the big differences in providing medicines like the GDF does for TB? What are the differences, do you think, between TB programs in countries and what exists for asthma in countries? Now, I guess this is going to be, if you think about some of the things that I've been saying, what do you think are some of the big differences between TB programs in countries and what's available for asthma? There was a reason for asking this. Have any of you worked with TB programs or done some interviews with them? Or
Yes.
You have? Yeah. You're going to propose them?
I mean, obviously the length of treatment, if TB is 6 months to 2 years, so that asthma is a chronic disease, so that would impact how much you have to buy and what quantities and for what time period.
Exactly,
That would
yeah.
impact.
Yep, huge, because asthma is chronic. People have it for the rest of their lives. Donors don't want to give money for, they want to give money often for products that they can get recognition for. It makes me sound awfully cynical, doesn't it? But this is a reality. They will be much happier giving money for TB or HIV medicines when they can see somebody's cured. Much more reluctant to give money to asthma. People need medicines for the rest of their life. I know that doesn't make sense if we say that with HIV, does it? But somehow, with HIV, we've managed to get that whole phenomenon attended to a lot more adequately than with asthma. But that's a very good point with the TB programs. It's a lot easier to control the purchase of medicines for a 6-month period, and how many medicines you need, and etc. and amounts than it is for asthma. Yeah, what's another?
In India, the DOTS the treatment is working pretty well in the government agencies. But what has also been seen is that in the private sector, they're actually asking for very unnecessary tests to make money. And I think one of the tests, though I wouldn't really know too much about it, is the ELISA test. And many of our doctors in the government do say that is not a test that is really required to be run on everybody, but the private sector is actually doing it. The private hospitals are doing it. So again, it is big money, big business there. But yes, DOTS is doing pretty well. but we still need a lot more awareness than what we are really giving.
Yeah, in India, there was this TB as a national campaign. I mean, Government of India has launched a campaign. Like the private doctors, they have to inform the government if they find any TB patient, and that campaign has to be run through doctors, as she is saying. But regarding asthma, nothing. I mean, government front, there is nothing like, it's the private doctors or if anybody can afford it. So nationally, you are talking about campaigns. No, in India, it's TB campaign is of course there, but nothing about asthma.
Yep. This is exactly, you mentioned the DOT strategy. So for TB, we've got this internationally accepted strategy that's been there for ages. There's national TB programs, there's a structure to engage with, there's organisation. We don't have this in for asthma yet. Countries don't have, they have people, specialists working on asthma. It's quite a diverse group of people who might be interested in asthma, some of whom might be heavily influenced by pharmaceutical industries. And so there's not this organisation to be working with. When you look at TB from outside of TB, it's actually quite interesting to analyse the amount of work we've done in TB over the decades and the impact it has. No information system. TB, national data. We know what's happening. We know what's happening with the how many people have TB, what the outcomes are. Most of the countries don't have any data collection on asthma at any level, in fact.
International agencies also want information about TB, but WHO, I don't think so. I mean, it's no concern about asthma or anything.
Yeah. Why do you think people want to know about TB, if we're being slightly cynical again?
Because you can get
it's complicated, it spreads very fast. It spreads very fast.
Be infected by asthma.
That's right, exactly.
You can be infected by tuberculosis.
Yeah, so exactly.
Like earlier said that in a waiting room, 4 hours wait can give you TB.
Yeah, one of the speakers said.
One of the speakers said, very alarming.
Yeah.
In a waiting room, if you're waiting for 4 hours and somebody sitting beside you in India, you're gone.
Coughing away. Yes, no, that's exactly it. Another point over here.
I think in many countries, infectious diseases like TB and HIV, they are all integrated into the epidemic diseases surveillance system. So that's the reason why we don't have a data bank for asthma, because it's not killing people and then it's not infectious.
And because end of the day, you're actually, whenever you're talking about the endemic or pandemic, it's all related to the how many people are actually dying. So when the part of India survey, when you actually list all the diseases and you ask someone, there is a survey, so asking whether you have any kind of chronic disease or any infectious disease or anything, the option of asthma is not there. So end of the day, when the option is not there, there will be no any possible policies and there will be no any kind of national of things.
Yeah.
And non-communicable diseases are actually including in recent past. I mean, in 2008, 9, so it's not that much big.
Yeah, no, those are all excellent points. The NCDs that we're going to have to change. This is going to change, and you are going to be seeing a lot of activity, hopefully, to rectify this. And it means that countries are going to have to change the way they do collect and analyse data to be able to see what we're doing with NCDs and are we what is the burden and how are we doing? Are we managing with our interventions to make some improvement with NCDs? So,
Can you tell us how many people in the world suffer with asthma? We have it in our survey.
Oh, well, exactly 235 million. Sometimes you see 300 million, sometimes you see 235.
Yeah.
Depends which year of the WHO fact sheets you look at. Yeah.
It's a huge number. It's hypothetically or
these are all estimated because these are all estimated. Yes, and this is partly because nobody really collects data.
That's what I'm saying. India, they don't collect data about asthma.
Forget about the asthma. They don't have even India. We don't have the exact number of tuberculosis patients because we don't have any survey for the last 60 years.
Oh, you mean prevalence?
It's just a sample survey, and we are actually calculating with it. For the last 3 years, we are actually struggling for the tuberculosis patients.
Yes. I think with the asthma, it is important to note this could be way higher. Because in low-income countries we have some surveys. Some of the best data we have is from what's called the ISAC surveys. These are prevalence surveys done in countries around the world looking at the prevalence of asthma in children, young children and 13 to 14-year-old children. And Professor Asher, that I mentioned, who will be speaking on the second, she has been involved in this initiative which lasted for 20 years, and they looked at studies over 20 years of asthma. So all of the clever people who do the estimations of projections and estimations of how many people in the world have X disease, they take all of these things into account and put it into complicated things that I don't understand and come out with these estimations. But certainly what the studies like ISAC have shown is that the burden is increasing. So over the time they've done these surveys around the world and the burden is increasing, and it's increasing in low-income countries. So we know there's definitely a big problem, and it's getting worse. Yeah, it's getting worse. Yeah.
Is asthma related to air pollution? Because I come from China. With very bad air pollution, we usually have a PM 2.5 reading up to 300 or more than that. But I seldom see people around me suffering from asthma. So
you seldom see people. Yeah. We always say that the exact causes of asthma are not known, but we know what triggers asthma attacks. So there's two different things to understand. Something causes you to develop asthma, so you're going to be somebody who is prone to having asthma attacks. And then there's the causes, and then there's the triggers. And the triggers are going to be different from the causes. And they might be dust, they might be animals, they might be plants, they might be pollution. So the causes are very, very complex. And you will have some real experts here at we have a workshop also on the Thursday on asthma. So there'll be two people talking about global epidemiology of asthma and about the ISAC surveys. So there's two really top people. If you want to interview them, it'd be a very good opportunity to. But certainly the pollution is a huge trigger for people with any type of respiratory illness. And probably, I don't know whether maybe you don't see them because they simply can't go out. They have to learn how to manage their illness, and they probably don't go out when the pollution is very bad. They might be at home if they're very, very bad. Yeah. Oh, sorry, you had a question first.
It's not documented, and the research is in its very initial stages. But in Karachi, doctors have been sensing that every time a widespread incidence of violence or a blast or something like that happened, doctors were seeing more patients of asthma in hospitals. Would there be a connection? Possibly it's...
What did you say when there's been a
bomb blast
or
a lot of firing incidences, grenade incidences?
Panic
attacks.
Probably could well be a combination of the actual explosion and the pollutants in the air, and plus the state of people who are distressed as well. Yeah.
But
it's not.
Is there a possibility to actually cure the asthma by some another medicines beyond your allopathy and your homeopathy?
And you bring that up, right? Well, we've only got a few minutes left. To cure asthma, we usually say asthma cannot be cured. It can be managed. It can be managed for life. Some children develop childhood asthma, and then it goes away, seems to go away, and they're not worried by it as they grow older.
Why I'm asking this question, because in India there is one province called Hyderabad, which is where it is a very huge temple. There is one special day when all the women and all the men are in the crowd, more than lakhs people, and they pour a live fish, a small fish, in the into the mouth, and they are actually asking them to get into it. Now after that, most of the people are saying that they are cured. So whether it can
so with asthma drug facility was on the wrong track. Classic. Wow.
From that sense,
That's
actually,
fish
I thought
therapy.
that
That's
Asthma is
called
one of
fish
the biggest
therapy
problems.
and fish
Yeah.
therapy. There's a live fish, a particular variety of fish, which a particular person of a particular family
It's
that
carried out.
pushes into the gullet of a person with his finger or something, and then
But
he
then
swallows
there are
it and then
researchers to say
says
that
they are
this
fine.
is just psychological, it's not a
And
cure.
we asked so many people whether you have been cured or not. They said no, we are cured. I mean, it's completely kind of supernatural.
Yes, I didn't talk about the psychology of patients as well in this, but obviously sometimes it's interesting. Sometimes in countries there are cultural practices, traditional healers, and it's interesting, particularly with TB, this is something that comes up. We have to take an approach that is going to be compatible with the cultural beliefs in the country or the community maybe. So you might work to ensure that TB patients, they will still go and see their traditional healer, but the traditional healer agrees to refer them to the TB program so that at least they get the medicines. So I guess if you are able to talk with the people there, you might say, could they, in addition to swallowing a fish, also go and consult with the health care facilities to have something other than that. It was a very interesting anecdote though. How are we doing for time, Linda? We're pretty much
5 minutes.
5 minutes, okay. So
So this was a story I'd done on asthma last year. It throws up very interesting statistics. Across 19 schools in the city, 3,497 children were surveyed, of which 7% had underlying asthmatic symptoms, which means that they are vulnerable to getting asthma, and that their peak flow rate, that is, the amount of air that they can blow out of their mouth as compared to their height and weight, is not at the optimum level. It's very low. So you are asked to blow in a machine. I went through it myself at the hospital because I had allergic bronchitis, and you can't blow for enough. So they say blow very hard for 9 seconds, but you can't do that. You can do it only for 2 seconds, 3 seconds, 4 seconds, So that's kind of arduous. And these children were basically vulnerable. So they say that 7% of all the children might develop asthma in future. And they related it to cold climate, to pollen, to pollution and things like that. So a lot of children who are at the risk of developing it don't know it. So the doctors there are saying that you better know that you will be vulnerable. So yes, that's the problem there.
yeah, and that's that leads into something. That's one of the ways of managing asthma is helping the patients work out what are the triggers. So then the family can, if some of the triggers are that cold and damp at home, then you can try and make the home environment drier, and if it's dust, then you can get rid of the carpet. Anybody who has asthma should get rid of carpet immediately anyway. But so managing asthma is partly to do with medicines, but it's a lot to do with sort of your environment as well. Being able to recognise the symptoms and know what to do when you start to become.
So what they're doing right now is they're visiting homes. Doctors are visiting homes with researchers, and they're putting up slides on the window with adhesive so that the pollen stick into those slides, and then they're observing it in order to realize that in some areas of Mumbai, coconut pollen and hibiscus pollen triggered cases. So they compared asthmatics and non-asthmatics with the controls, and they found out that these pollens are leading to the trigger apart from pollution. So whoever is asthmatic has to get rid of the hibiscus plant in their house,
or has to see that they're not anywhere near to the coconut trees.
Mm-hmm. And this is where it's so interesting because every different country seems to have different things. I mean, basically it's an inflammatory reaction of your lungs. Asthma is it's your lungs reacting to something. So it's sort of impossible to think of getting rid of absolutely everything that might irritate them. So it's quite, there's a lot of different things around the world. I should just we've got to finish up now. Although we're still going to be talking about non-communicable diseases in your next session, so that's great. Conclusions. So the conclusions is that we hope that low and middle income countries will ask their governments for quality assured medicines for asthma and for NCDs and get budget allocated for them, hopefully improve the rational procurement of medicines. And the union is going to try to transfer some of these functions of the asthma drug facility to another agency that could continue to provide access to these medicines, because a lot of countries still really need the medicines to get their programs, their asthma activities going. Right. Okay. Well, I think that's wrapped up. Thank you very much for such a an interactive session there at the end of the Thank you.